Welcome to Thinking Thoracic, the podcast dedicated to exploring the advancements in thoracic surgery. Brought to you by the Society of Thoracic Surgeons. This podcast features leading thoracic surgeons discussing and debating the latest research, surgical techniques, and trends to expand your knowledge, challenge your thinking, and help you stay ahead of the curve. Whether you're a thoracic surgeon, advanced practice provider, researcher, or industry professional, Thinking Thoracic is for you. Let's get started. The Society of Thoracic Surgeons Thinking Thoracic podcast is sponsored by AstraZeneca.
Hi, everyone, and welcome to Thinking Thoracic, an STS podcast. I am one of your hosts, Erin Gillaspie, and it's my absolute pleasure to welcome you. I'm so excited to help bring you the latest and greatest in thoracic surgery. I am so delighted today to be joining you guys from the STS. It is STS 2026. I'm here with one of my favorite co-hosts, Hari Keshave.
Hi, everyone, and thank you very much. We're really excited for the STS, and we're excited for today's talk.
So you guys, we have such an exciting topic today, and joining us to talk about it is Dr. Awori Hayanga. Dr. Hayanga is a brilliant professor in cardiothoracic surgery at West Virginia University Medicine. He's director of the West Virginia University Heart and Vascular Institute, as well as the ECMO program, and medical director of research. He is here with us today to talk about a topic that really is such an important one we don't talk about enough, and that is emphysema and how we manage that. So welcome. We're so excited to have you. Thank you for joining Thinking Thoracic.
I am so excited to be here on this sunny day in Louisiana.
Yes.
And to be here discussing this because emphysema is the third leading cause of death. And we forget that it kills up to 3 million people every year. And it's a big deal. And we don't talk about it enough.
We don't talk about it enough. And not just the mortality, but the symptom burden that patients living with emphysema experience on a day-to-day basis.
I could not agree more. And to a certain extent, before the lung allocation score kicked in 2005, patients with emphysema would go to transplantation. And they were prioritized because of the duration of time that they spent on the wait list. But after the allocation score kicked in, candidacy was really based on acuity, and pulmonary fibrosis really began to be the big driver for lung transplantation. And emphysema patients, or patients with emphysema, were neglected. And so looking at management of emphysema, one really has a very short list: standard of care and the use of bronchodilators. What we have seen is that really doesn't help them much, and we need other items in our armamentarium, and certainly lung volume reduction surgery was one of those.
So you brought up lung volume reduction surgery, and as surgeons, this is one of the trials, the NET trial specifically, where it's a randomized controlled trial where thoracic surgeons were involved. Can you tell us a little bit about that trial and how that has changed lung volume reduction surgery for better or for worse?
Absolutely. And the NET trial is actually where this whole story starts. And as you so appropriately described, lung physicians, to so to speak, were involved, and thoracic surgeons were involved in the NET trial. And it was a multidisciplinary consortium. It was a very well-designed study. It was a very well-executed study. And in many ways, because it was done so well, its granular nuance came back to hurt it, because subsequently other well-crafted trials that were less rigorous came in to challenge the high perioperative and mortality and morbidity that was associated with the NET trial, and was used against the NET trial and moved management of advanced emphysema away from lung volume reduction surgery.
So can you tell me, or tell us a little bit about which patients in the NET trial really benefited from lung volume reduction surgery.
Yeah, absolutely. And it was partly because of this. A very narrow criteria was created. Approximately 600 patients in each arm, randomized to either undergoing this LVRS or standard of care. And what we found was that in patients, a subset of patients with upper lobe predominant disease, which subsequently began to be referred to as heterogeneous disease, with low exercise capacity and upper lobe predominant disease with FV1, as we knew, less than 45%, and TLC greater than 100%, and residual volume greater than 150%. These patients did better after lung volume reduction surgery. And that small segment of patients then became the only ones who would be offered anything to do with lung volume reduction surgery, and that became the criteria for reimbursement by Medicare.
One of the things that I loved about that trial, as you alluded to, is beautifully designed, and there was a lot of really well executed inclusion criteria. And so they were really vigorous at collecting baseline pulmonology and pulmonary data, making sure patients were involved and enrolled in pulmonary rehabilitation. And then they continue to capture things like patient-reported outcomes throughout. And that's something we talk about a lot nowadays, but that was not something that we popularly saw incorporated in clinical trials, really of that era in surgery. And so I always am so thrilled to see that component of it, but also, gosh, what forward-thinking authors and really clinical trialists at that time to include that as such a critical criteria of that study.
What a great point. And actually, now we see that we have to build that into our NIH grants. And you're so right that this was very forward in the thinking and in the construction of that trial. And that is true because even subsequently, the VENT trial, the IMPACT trial, TRANSFORM trial, all these other trials have not been able to replicate that kind of visionary thinking. And it is, at the end of the day, one of the most dramatic things you see in the clinic is a patient comes in and says, Dr. Gillaspie, I no longer require oxygen, whereas I did before, even doing the easiest and least strenuous of activities. And to that patient, yes, a minimal clinical important difference of 15% may mean something, but nothing means more to them than being able to really conduct the activities of daily living without the encumbrance of requiring oxygen or the limitations that they once had.
Absolutely. Now, you mentioned the key cohort of patients that really were shown to have demonstrable benefit from a surgical intervention as compared to standard of care medical therapy at that time. So we have our upper lobe predominant heterogeneous disease, those with sort of that low exercise capacity, but pretty much everybody else, they said, hey guys, we're not really seeing a meaningful difference, so probably not folks we should consider for surgery. And then they also separated out this high-risk group. So when I think about the trial, I actually think about 5 groups, right? Those 4 groups that they gave names, and then the high-risk ones that they took out of a lot of the analyses, those patients that had the FEV1s less than 20%, the DLCOs less than 20% that had the very high mortality rate. But a lot of, I think, the interpretation of this trial in general hangs on to exactly what you said, the morbidity and mortality rate, which we know is always going to be a little bit higher right after surgery. But then as we start to get out to that 6-month time frame, we see that now that surgery arm is performing better than the medicine arm, and we sort of see that crossover. And it makes me wonder sometimes if some of the groups were potentially underpowered as we start to divide those cohorts into smaller and smaller and smaller groups. And maybe we missed some patients in that original study who could have benefited. And we really hung our hats on those categories pretty vigorously after that trial.
Erin, you've raised so many important points. I don't even know where to begin, but I'll try in reverse chronology. So you said a 6-month follow-up. After 6 months, you see this slight improvement. And you would then agree that if you didn't follow the patients beyond 6 months, you wouldn't see that improvement.
Correct.
No. Yeah. So enter 2008. We have the VENT trial. The Venn trial is the first trial that starts to flirt with the idea of endobronchial valves and bring it out into the literature. This is a study that enrolled less than 120 patients, followed the patients up for no longer than 3 months.
Wow.
And then witnessed an improvement in FEV1 of 4.5%. An improvement in 6-minute walking test of 2.5%, which equates to 9 meters, which is shorter than this room.
Yes, it is.
Yeah.
So this was the introduction of endobronchial valves because of all the things that you just stated. The NET trial identified a small segment of people, but left a lot of patients with advanced emphysema with no choice, no option. So very, very cleverly, the valve industry looked at all these patients that surgery was ignoring and said, surely something can be done for these patients. But let's not follow them longer than 6 months, because inevitably you might see a difference you don't want at that particular time. So the Venn trial comes out, then the impact trial comes out. Why is that important? Because during the Venn trial, they found serendipitously, again, quite by accident, that patients who had complete fissures seemed to do better, completely by accident. So the same company, which we will not name, designs a device that can tell you if the fissures are complete physiologically by flow, which traditionally, with the improvement in CT, we could determine through digital imaging without necessarily having to do this extra step that is produced by the device company for the device that they're trying to introduce into the market. Then the Transform trial comes out, and suddenly it's okay to treat patients with upper lobe and lower lobe disease, and homogeneous as well as heterogeneous. So suddenly, all the people that you just said were not going to be treated with LVRS had an option. And after that, we had the Liberate trial, which then introduced the issue into the U.S. market and randomized for the first time now American patients in the United States, as opposed to the European trials that they had thus far done up until then. So it was, you look at it and you say, oh, maybe just a series of coincidences. But what you just described there is the entire strategy behind the endobronchial valves. And this is not to say that this is a negative thing or be pejorative about that effort. It's just that 3 million people die of emphysema, and the NET trial was only going to offer a very small segment of them success or treatment, especially in the absence of transplantation.
That was great, and it was a great overview of all the different trials that we should be knowing about with endobronchial valves. You recently looked at endobronchial valves in surgery, and I think you have a paper in the Annals. Could you tell us a little about that paper and kind of the nuances of it and kind of what the final takeaway message is from that?
Absolutely. And there are actually 2 papers, and both of them have CME offered to them, so our audience can get some points as well as listening to us.
That's great.
The first one was just to look at the lay of the land, because just as you've both pointed out, that so much has happened since the NET trial. The NET trial was all about a sternotomy and performing bilateral lung volume reduction and a 14 to 21 day stay in the ICU. Air leaks, subcutaneous emphysema, blowholes, we all know that. You all know that routine. That's no longer the case. And as you have trained after me, you do this the way we do it. We do lung volume reduction surgery robotically. We do one side at a time. We use reinforced staple loads. We use Progel as a pneumostatic. We have good pain control. We have rib blocks. We perform a mechanical pleurodesis, a tau pleurodesis, and a pleurectomy. We have limited the chance of air leaks.
So during each surgery, you're doing a pleurodesis, both mechanical and
talc.
chemical talc.
Yes.
You're putting the Progel.
Yes.
And you're doing reinforced staple fires
and a pleurectomy.
And a pleurectomy.
Yes.
A full pleurectomy, partial?
Apart from about the 6th rib, we pull down the pleur like a blanket over the lung. And it works. These patients go home in day 4, day 5, which may seem long compared to a lobectomy, but it is pretty good for LVRS.
Well, that's pretty amazing.
That's huge for LVRS. I agree. Now, are you, just out of curiosity, because, obviously our listeners are all surgeons and some do this case, some don't, some might be thinking about starting to do LVRS surgeries. You're setting up a robot. Are you using 3 arms or 4 arms? Just out of curiosity.
Excellent question. 3 arms. I don't use
Love
the tip
that.
up for that because, you don't need it. Because you're using reinforced staple loads, you have to have an accessory port for the assistant. So you're going to, you don't need to use the Da Vinci stapler.
So you're using a non-Da Vinci staple fire.
Correct.
And you have an
GIA.
assistant doing that.
Exactly.
Wonderful.
So you hold the lung as gently as you can, and you don't touch, you don't touch any part of the lung that you're not going to resect. But you want to resect at least 300 to 350 cc's of that upper lobe, and sometimes also the superior segment of the lower, right lower especially. So it is, it's delicate to avoid damaging other parts of lungs that really look like bubble gum often. But that upper part of the lung doesn't work. And when you resect it, you give the space for good lung to do its job. And when it does its job, the patients get really happy.
And are you doing one side in the same sitting, doing the other side, or you bring them back? How often do you wait?
Great question. I wait 6 weeks between the two. And I'm not courageous enough yet to do both, because I always worry that a pneumothorax on the other side could be devastating in a tension physiology type of way. So I let one heal and let the patient feel the benefits of that healing. And just when they're up and running, and knock them down again. No, but then we offer them the second, the contralateral side. And then at that point, they typically have become believers. And I'm waiting to compile a series of just patient testimonies, matched then with their digital improvement in FEV1.
Talk to me about your chest tube strategy, because this is something that we talk about a lot, especially with this degree of delicate lung, right? We worry a lot about air leaks in these cases. Nice to have control of the space for the chest tube. Obviously, we know that suction propagates air leaks and can cause problems. Are you putting a chest tube? Are you putting a Blake? How fast are you taking it out? Talk me through your strategy with this.
Great question. So we had a shortage of some chest tubes and switched to silicone in between. So my experience over the past 2 years has been affected by inventory. But typically, we just have a single chest tube that sits there directed towards the apex, and we try to avoid suction as much as we can, right? Try to avoid suction, try to avoid BiPAP, try to avoid reintubation. But this is why I think the NET trial gets a short shrift, because we've improved so much in terms of our care in the ICU. We've improved so much in terms of our pain management in the OR. We've improved so much in terms of our extent of invasiveness that to compare 2003, and remember, there were accruing patients from the 90s.
Yeah.
To compare that to interbronchial valves that are placed in 2025, 2026 is not fair. These are apples and lemons.
Absolutely. And I mean, if you think about the NET trial, to your point, out of the 600 operative patients, the vast majority of them were done by sternotomy. Correct. Sternotomy and bilateral, same time approach, maybe 100 of them were done by VATS. Correct. And that was at a time that VATS was so in its infancy, we often didn't have dedicated instruments, even that we use today. So even VATS then, compared to today, is not the same surgery.
Another excellent point, that even the VATS that we are doing now isn't comparable to what we were doing in the past. And you raise a good point, because when we looked at this, to the point about the studies, we first looked at just the lay of the land, interbronchial valve placement and lung volume reduction surgery in 3,200 patients, 800 of whom had undergone valve surgery. Now, since the valves received FDA approval in 2018, the uptake has been exponential. So we did a subsequent study just looking at outcomes, reimbursement, reintervention, readmission. All of these things favor lung volume reduction surgery. And between 2018 and 2024, the numbers had quadrupled in terms of endobronchial valve placement. This is the thing. Pulmonologists have sold it well, and patients perceive this just like the Saber-TAVR, just like the cath-BCI CABG. They see this as being the thing to do. It's minimally invasive. I can get in and out of the hospital in 2 days, and why should I have an incision? And we don't refute that. This is not pitting lung volume reduction surgery against the endobronchial valves. This is saying, can we talk about this as a group and then stratify these patients? I'll tell you something very interesting about those endobronchial valve trials. The VENT trial, the IMPACT trial, and the TRANSFORM trial. Those are the 3 trials that led up to the FDA approval. None of them was risk adjusted. None of them was risk adjusted.
Oh, wow.
And that to me just blows my mind, that what are we comparing if we are not looking at this in terms of making comparable groups? The other thing that we found when we risk adjusted our valve versus lung volume reduction surgery was that patients who get endobronchial valves, at least in the last 7 years, they typically have lower comorbidity scores, lower frailty scores. So they are less sick, but they have higher mortality. They have higher readmission. They have higher reintervention. They have shorter hospital stays, but they have higher costs. So let's talk about it as a group.
Let's break it down by each one of those topics, because I think this is really good to delve into. Let's start with cost, because I think that's a place that really surgery gets criticized a lot, right? We all talk about operating room, most expensive space in the hospital. Often, pulmonologists have a suite that might be less costly as far as real estate. But often when people think about cost, they isolate it to that one incident, but you don't take into account the fact that when valves first came out, they did a lobe at a time. Then they did maybe 2 lobes or 2 valves. Then maybe they started tackling, so where it's higher rates of reintervention over time. We don't have the same length of hospitalization, to your point, but we have more readmissions, complications, things like that. And so it's so interesting to hear you say, actually, the cost doesn't favor the valves, as it turns out.
And those are very good points, Erin. And that's it. You nailed it on the head. It is the cumulative cost of care for that patient per capita for treatment of the advanced emphysema. The valves, in exactly the way that you described it, was described to me as what you're describing is a learning curve. And that as the proficiency gets better, the number of readmissions and reinterventions will also commensurately fall. But my argument against that is, yes, you're telling me that that's a learning curve, but you're still using those numbers to hammer the net trial and say there was 7 to 8% mortality, so that's a terrible trial. But wait a minute, give us time. Give us time to prove to you that minimally invasive lung volume reduction surgery will provide you numbers that will be compelling when you're presenting them to patients. And to your point about the type of surgery that's being performed, we've moved away from median sternotomy being the predominant, and now it's a VATS. So 66% in the trial, in amongst Medicare population, 66% undergo VATS, and then 20% is robotic. And so open thoracotomies are the small minority. And that speaks to then the post-operative pain experience, because it is the same. You're dealing with the sort of same kind of pain profile as your lobectomy patients, as opposed to what it was before, which was a combination of things that was far different for lung surgery.
I'm going to change gears a little bit now. So my pulmonologist came to me the other day, said, "Hey, you know what? Let's start a program. Let's start doing this." What do you tell surgeons now, like myself, and you have a pulmonologist that seems eager. They want to start doing more valves, but they also want to do the right thing. So they're trying to get the surgeon involved. How do you start a program? How do you move forward with this? What's your first type of patients you should be looking at? What do you recommend?
Great question. And the fact that your pulmonologist came to you with the idea already says you're ahead of the curve, because that means there's dialogue. So you're talking to your pulmonologist during a tumor board meeting, but also outside. And in these non-cancer patients, you'll find that the more you discuss, the more cases you will both do. And really what it ends up being is a win-win, because patients love the fact that Dr. Gillaspie is discussing this with Dr. Schroeder, who's a pulmonologist, and they just feel this is a very comprehensive discussion. This is a very thoughtful way to manage my pain and my suffering that comes from advanced emphysema. So the first thing is dialogue, that we have to talk to each other, and then we have to agree what are the criteria. Now, the Celeb trial came out, which is really based in the UK, though it randomized patients in England, Scotland, Wales, Belgium, and the Netherlands. But if you look at the selection criteria for that study, they chose patients whose FEV1 was less than 60%. Now that kind of throws everything into a bit of a quandary, because we say for Medicare criteria, it should be an FEV1 of less than 45%. And so the endobronchial valve literature also follows that to a great extent. So now to have the only other randomized controlled trial since the NET trial not follow what the original criteria was, and then conclude that, well, there's not a difference. You say, but were we measuring oranges and oranges to start off with in the first place? Like, this is already going to be confusing. How do you interpret the literature? So sitting down with your pulmonologist and agreeing what are the criteria. We can't just invent criteria each time we want to do a study and say, now we're going to use 75%, because I don't think an FEV1 of 60% is that bad. Yeah. And so the consistency with the Medicare criteria, I think, is useful, 45%. The agreement about total lung capacity, 100%, and residual volume, 150%. And also then a sense of what kind of profile can make it for surgery versus not, so that we're not just taking the dregs or the leftover patients who who don't qualify for anything. We would then be injecting our own biases to each group. So we can keep ourselves honest and say, well, I'll take this patient because they are fit for surgery, and Dr. Johnson, the pulmonologist, can take that patient because we don't really want to inflict a surgical trauma on them. Let's see if they can go for something that's bronchoscopic rather than invasive from a surgical standpoint. And then let it evolve in the way that all the stakeholders feel that they have ownership and that they have a say, but then based on scientific evidence from the past that will allow us to adjudicate our results in the future. So if I'm doing FEV1 of 75% and you're doing FEV1 of 30%, my outcomes are going to be better because I will already achieve a target goal of FEV1 regardless of what I do with that patient. And you'll be struggling because your patients are far more debilitated than mine. So agreeing on criteria like that helps us set up programs that can then be compared against historical cohorts as well as the future.
Do you do anything to prepare your team? Like the ICU? Do your patients go to the ICU after surgery? Your nurse practitioners, outpatient? Is there anything that you do specifically there?
Another great question. They all go to the ICU because I'm superstitious. But what I've realized is the ICU is pushing back against me, saying, why should this patient come?
They look too good.
They look too good. And I say, you guys don't know the history of this problem. You don't know the history. Things have evolved that much that they don't realize that these things go south very quickly. But I'll tell you, the big conversation I have is with the anesthesiologists. I say to them, let's be very careful. This patient can have a pneumothorax while the robot is docked. We have to be able to recognize that. Don't just give the patient vasopressors and then say, halfway through, oh, the patient's been on neo for the last half hour. I've been titrating up the norepinephrine. like we need to know, because if there's a sharp drop in pressure, the contralateral side suffers from the same problems we're seeing on the ugly lung that we're working on, and that lung could have a pneumothorax and cause severe problems. We also say that the patient can really accumulate a lot of CO2 during the case. We have to have an A-line, because they've also began to get a little nonchalant and say, why should we do an A-line for this case? Let's have an A-line so that we can get a blood gas before we come off bypass, before we extubate the patient, because we could find a PCO2 of 100 and then extubate the patient doesn't ventilate, pH is 6.1, 6.9, and suddenly they arrest. And so the communication is more with the anesthesiologist to try and have a soft, safe landing for the patient as we complete the procedure.
I love that team thought process. One of the things that I love about the field of thoracic surgery in general is so many parts of what we do is a team sport, and this just continues to emphasize that emphysema is a team sport, and you need anesthesia, pulmonology. But then also the team members that immediately came to my mind too are my physical therapists who work with them both pre and post-operatively, but also my cardiologists, right? Because as you were talking about some of those inclusion, exclusion criteria, some of the most critical decision-making is actually beyond the strict PFTs. It's understanding their cardiac reserve physiology, pulmonary hypertension, because boy, we can get into a lot of cardiac trouble with these patients if we're not careful. Often the lungs are precipitating a lot more right-sided heart disease than many people think about, right? Everyone thinks about the left side of the heart. We as lung surgeons, we're always like, right side, right side, right side.
Exactly, so true. And we always want to know what were the PA pressures? What was it like? I mean, let's get the echo to know what is going on the right side of the heart. And even in the CT, I always look at the size of the PA, because I say, if that is bigger than 3 centimeters, I'm worried, and I'm there in the room as the induction occurs, because we always say we may need to place this patient on ECMO if things go south.
Have you had to do that?
I have not.
That's great. That's good.
And in West Virginia, we don't boast having a very healthy group of citizens. But that has not happened, and I credit to the anesthesiologist, the gentle induction that they have become used to has allowed us to put these patients under anesthesia gently. It takes time to get everything going, because the intubation, the double lumen checking it, and getting the A-line in and getting everything situated takes time, but it's worth it, because then the procedure goes smoothly, the patient's extubated, there are no issues, and hopefully there's only a minimal leak, if any. And I always, as soon as we inflate the ipsilateral lung, I always go back to the anesthesiologist, the head of the bed, to look and see the volumes, to see how much they're giving and how much they're losing before we get the chest tubes in. And I remember a couple of years ago when you'd place the chest tube and your heart would sink because you'd see a blowing air leak, and that's part and parcel of it. Sometimes there will be a leak. We've been fortunate, really, 2024 and 2025, we've had minimal leaks, but I know leaks happen, and we will get them, and we manage them, and so far, so good.
So it's 2026. Hari's building his beautiful program.
Yep, it's starting.
You've got this amazing pulmonology colleague. So how should we be making decisions nowadays, given the advancements in surgical techniques are better, ERAS protocols? Which patients really, truly should we be considering for surgery versus valves, and who still is going to be most benefited by medical therapy? Because I actually think, I always worry sometimes we shift the pendulum too far one direction and too far back as a corrective maneuver. How do we get into this sort of middle zone where we're doing the right thing for as many patients as possible?
That's a great question, Erin, and I think that's where we need to focus next, is what are the criteria for surgery? Because things have changed since the NET trial. It's not just upper lobe predominant disease patients that get volume reduction. They're getting endoscopic volume reduction when they have lower lobe disease, when they have homogeneous disease. That's the TRANSFORM trial. And even then, another trial called the IMPROVE trial came in, and it introduced a second valve manufacturing to the market. So we have the Zephyr valve, and we have the second valve that was made by the Olympus team. So there are two. But what those trials showed us is that it's not just upper lobe predominant disease. So the inclusion criteria needs to be broader than that. The inclusion criteria should favor patients who can undergo surgery. So if the patient is fit enough for surgery, let them have surgery. But if they're not, if there's some other debilitating concomitant problem, they should have valves. And I think there's enough as a cohort of patients with advanced emphysema that not all of them should get one or the other. And I think that that's the sweet spot. It hasn't been defined. There's the gap in the literature.
I think I'm going to task you with filling that for us, please.
More homework. More homework.
Yeah, more homework. Here's next year we want to hear an update.
We'll have to. We'll be coming to you as well, to your program.
No, this has been fascinating. It's been amazing to hear from you about the nuances of the surgery, nuances of the trials, the valves, and how we're hopefully going to be having a resurgence of surgery in this space.
Will you make sure you start that program, Hari? I'll be checking.
You got it.
Any closing thoughts for our listeners, major key things you want them to take out of this conversation today as they are continuing to take care of this super important patient population, or like Hari, building a brand new program?
Exactly. No, I first want to say something that you said before we started the podcast, which was your training between 2013 and 2016.
Yeah.
And how at that point, lung volume reduction surgery was already on the decline.
It was.
Yeah, it totally was.
So this is what I want to say. The NET trial shows up in the board exam still. And so a lot of our graduates in practice now just have rendered that into the museum of their minds, that is just a historical artifact. And everyone's concentrating on segmentectomy versus lobectomy. But here's what I'll say. There are a lot of patients with advanced emphysema who need your help. And you are the right person to partner with your pulmonologist in a way that's very similar to the tumor board. It can just be a group email. Hey, I'm just sending you the name of this patient. I've got a screenshot of their CT scan. FEV1 is 37%. Then they're strong enough to walk up a flight of stairs. I'd like to do volume reduction surgery on this patient. And to a pulmonologist seeing this for the first time, that might be the first opening that they say, okay, so there can be a room for discussion about these patients. And then they'll start to tell you about their patients. And sometimes, and most times, a pattern of referral begins to build. You don't necessarily have to have the song and dance of a tumor board discussion on a Tuesday afternoon at 4 p.m. It can just be a common thread, common email that puts 3 or 4 of you on the same chain, discussing these patients, giving opinions. And people feel very flattered when you seek their opinion. And even more so when you follow their advice. And if they become stakeholders in your decision-making, they become stakeholders in your enterprise. And that itself starts to bring a community together to look after these patients. So that it's not just my way or Hari's way, it's our way. And then everyone benefits. And that's the tide that we want to raise all the ships.
Absolutely love that. I'm very blessed to have a pulmonology colleague, Dr. Depew. Major shout out to Dr. Depew, who is unbelievably collaborative in this space. And we talk about every single one of these patients. And I think of it as a gift to the patient, right? That you have as many people as possible thinking about how to take the best possible care of them as we continue to navigate what is a very complex space right now in decision making.
Couldn't agree more.
Well, thank you so much for your time with us today. This has been just an absolute treat. I'm actually feeling buzzy and excited about the resurgence of LVRS, partly because it's a fun surgery, y'all, especially because we're getting better at managing all of the air leaks, but also because, we have all these beautiful new minimally invasive surgical techniques. And there's a lot of opportunity to help a lot of really extraordinary patients. And there's nothing better than when they get to come back to your clinic and say, hey, doc, I get to go to the grocery store or to my grandchild's birthday party and not be on oxygen.
Without oxygen.
No oxygen.
No oxygen.
I totally agree. And just talking, I was feeling giddy just listening to how you're doing the surgery, what you're doing. I think hopefully we can have a resurgence of surgery in this field. And it's really exciting. And thank you very much for being with us.
Oh, thank you so much for having me. Let's do it.
I love it. I love it. Wishing all of our incredible listeners a wonderful rest of the day. You guys, welcome to 2026. We're so happy to be joining you from the STS meeting. We'll be bringing lots more super exciting updates to you. Please make sure to keep spreading the word about the importance of lung cancer screening and now the importance of getting involved in the emphysema field. Please keep taking extraordinary care of patients. And as always, keep smiling. To our amazing listeners, thank you so much for joining us today. If you have enjoyed the conversation, please be sure to follow Thinking Thoracic on your favorite podcast platform so you never miss an episode. Your support helps us to continue to grow, improve, and to bring you the most insightful conversations. And if you have a moment, we'd love for you to leave a rating or review. It really makes a difference. Thanks for tuning in, and we'll see you next time.
Thank you for joining us on this episode of Thinking Thoracic. The opinions expressed in this podcast are those of the participants and do not necessarily reflect the views of the Society of Thoracic Surgeons.